Very good. So, indeed, for the patients, this is the most troublesome situation when they are in progression or progress to acute myeloid leukemia, and therefore it is a really important subject at this point in time. We'll start with a little bit of a background. We know that, and this is a summary of a couple of papers, that acute myeloid leukemia, if you just look at the circle here, acute myeloid leukemia in a blue color is the most common reason for death of the patients as a single cause. But on the other hand, it is not that most of the patients with the myelofibrosis or MPN die from acute myeloid leukemia. The notion sometimes is the wrong one, that most of the people progress to acute myeloid leukemia. But as a single most common cause, it is obviously of interest to try to prevent it, to treat it, or to understand it so that we develop new therapies. And it is not as common in ET and PV as it is myelofibrosis. We all know that. The summary is on the right side. So usually we start asking questions, can we identify patients that are at a risk of a progression so that we can inform the patients about that risk? Can we be prepared or do something about it before the progression actually happens? And this is a subject of many papers. This is just one table from a very nice paper from 2014, a review by Rampal and Mascarenas on the subject, where they have a keen interest in developing specific drugs for patients in accelerated or blastic phase myelofibrosis. And you see, by traditional look, there are factors that are important in terms of the blood cell count. In ET, there is age, there are leukocytes, there are blasts, there are cytogenetic abnormalities. Okay, cytogenetic abnormalities that we know that predispose people to progression. And of course, there are also some therapies that we know that possibly can contribute to progression to acute myeloid leukemia that we do not use often much at all anymore. So historically, the traditional way of looking at progression is by looking at what is obviously there at disposal to a doctor: blood cell count, physical condition of the patients with the karyotype, and perhaps age, and then looking at whether we are actually making these people progress by providing certain bad medications, I would say, simply said. And further to this, this is one of the studies in polycythemia vera from 2005, where busulfan, pipobroman, and radioactive phosphorus were clearly identified as the culprit in increasing the risk of patients with polycythemia vera in their risk of transformation to acute myeloid leukemia. In this particular study, hydroxyurea was not identified, but as we heard yesterday from Dr. Schwartz, it's a matter of time and perhaps dose, and we need much longer follow-up for this hydroxyurea effect to be seen. On the other hand, I don't have hesitations to talk about busulfan, pipobroman, or radioactive phosphorus as clearly identifiable drugs with acute myeloid leukemia transformation. Now, we are in a land of genetics. This is a time for genetics. And the next question usually is beyond the karyotype, blood cell count, age, medications. From historical perspectives, what about our ability to genetically identify patients? And one of the papers from Dr. Teferi from a few years ago said that triple negative patients have a high risk of transformation. As we know, they have a high risk of dying sooner, but there is also high risk of transformation to acute myeloid leukemia, which is then tied to their increased risk of dying and early death. So not surprise here, but there was no difference in this study between the other driver mutations that were identifiable in these myelofibrosis patients in terms of risk of transformation, just the triple negative cases. Now, other non-driver mutations are very well known at this time and age, and Dr. Ranucci here published a paper in 2013 on the high-risk molecular markers in myelofibrosis that are known to shorten the life expectancy of the patients with myelofibrosis. But similar to what I said about triple negative cases having shorter life expectancy, those with, and in this case we have here SRFS2 and EZH2 and SXL1 and IDH mutations, each of these on its own, if present, would also increase risk of transformation to acute myeloid leukemia. And these names or abbreviations for these particular genetic abnormalities are perhaps important to remember at least for a few minutes, because we'll come back to that as we try to attempt to develop medications for these conditions. And we have, at least where I am at the moment, medications that are targeting particularly, for example, IDH mutations and splicing gene abnormalities as well. So these medications might be useful in the situations of transformation of patients with post-MPN acute myeloid leukemia. And I think it's safe to say that the transformation is actually a result of acquisition of genetic abnormalities, but also karyotypic abnormalities. I don't have a slide on acquisition of karyotypic abnormalities over time, but we can project the same, that there are not too many abnormalities like here in genetic way to karyotypic way when we talk from PV, ET to myelofibrosis and then to blastic phase. Many more abnormalities in blastic phase. So that is the natural result of genetic instability and acquisition of karyotypic and genetic abnormalities. We always wonder whether there are any identifiable novelties in those genes, not just the number. And we are all possibly aware that P53 is associated in a quarter to a third of the patients with acute myeloid leukemia after MPN, where it's hardly ever seen in a chronic phase MPN. We would then say perhaps that's a reason for transformation, but it's not that clear-cut correlation between the two. It is just the fact that it's identified much more often in acute myeloid leukemia. We can really say that is a reason for transformation. I don't think that that's possibility as of yet. We can discuss this later. Now, but the identification of abnormalities that are associated possibly with the transformation is a topic on its own. This is one paper from, again, a group at Memorial Sloan Kettering looking at the extensive list this time of mutations in patients that transform from MPN to acute myeloid leukemia. And here we have a JAK2, and then those, again, that we tried to remember from the prior slide, ASXL1, IDH2, P53 here, 27% in one paper here, again about 30%, and then SRSF2. So not just that these mutations predispose patients with myelofibrosis to transform, but of course, because these people do transform, they are present in many patients at the time of acute myeloid leukemia and perhaps are targets for new drug development, as I already alluded. The result of this kind of extensive analysis led to us to realize that acute myeloid leukemia that develops from myeloproliferative neoplasms appears to be completely different genetically than de novo acute myeloid leukemia, and this is one of the comparison. We have some of the markers here. We have in the de novo acute myeloid leukemia, the arrow shows FLT3 mutation, which is common, relatively speaking, in acute myeloid leukemia and hardly ever seen in the acute myeloid leukemia after MPN. We don't even test for that anymore. It used to be that we do because we thought FLT3 inhibitors would be effective in this condition, but it's hardly ever present in post-MPN acute myeloid leukemia. And so here, on the other hand, the NMT3A is common in the de novo and not very common, again, in secondary acute myeloid leukemia. So we traditionally have been using the same therapies for the two conditions, but there are actually two conditions that differ in the genetic background. They just present similarly and lead to untimely death, but perhaps we should think about changing the therapeutic strategy in post-MPN acute myeloid leukemia. Oops, sorry. And so how are we doing with our ability to successfully treat patients with acute myeloid leukemia after MPN? This is from 2015, and let's just look at this. This is blue line is de novo acute myeloid leukemia, overall survival, and what do we have here in yellow and orange is secondary acute myeloid leukemia from MDS or therapy-related acute myeloid leukemia. The worst one is the gray line, and the gray line is secondary AML, not MDS, which is the one that we are talking about now. This is the secondary to MPN. So MPN-related acute myeloid leukemia has really very bad outcome, and we all know that. That's the worst outcome of all if we can talk about subtypes of acute myeloid leukemia. Now, we do try to prognosticate even in this bad situation, and one of the factors was SRSF2 again, and that's why I'm looking to upcoming studies with the agents that would possibly affect this type of mutations. in this particular group of patients, because it seems that even in situations where the outcome is so bad, this is the JAK2 vasoskeletal reticulin, no difference, but here is mutated SRSF2 and wild type. There is a difference, and the median survival here is about a year if you have a wild type SRSF2. So there is some difference even within such a bad group of patients in their survival based on genetics. Now, it's indeed very bad for patients to transform to acute myeloid leukemia because the survival is so short. This is a very old slide from my friend Dr. Ruben Mesa from 2005, and you can see here a recapitulating experience that is still standing like that since 2005, that the average survival is between 2 and 5 months. This is the survival with supportive care, and these are patients that are being treated. So it's pretty bad, and I am always honest to the patients to tell them if there is a progression to acute myeloid leukemia, either we watch you or we do something about it, it's about the same. Doesn't really matter. There is one situation, however, that it does, and that will be the next slide. Here also is comparison of no induction therapy versus induction therapy, hardly any difference. We can calculate percentage difference, but that's beyond the point. It's so short. So induction chemotherapy does not appear to provide benefit to the patients with post-MPN AML. Exception has been noted by many that do transplant. This is also experience from our own MD Anderson look at 53 patients that was about almost 8 years ago. These are patients with AML after MPN that did not achieve CR or PR from induction, patients that did, but again, no much of a difference. But those that went to a transplant after achieving CR or CRI did well. So one possible scenario that is successful, as we know probably from our own practice, is to, if there is a need for induction, then you induce patients that has a donor ready and follow with the transplant immediately after induction, because they would otherwise relapse right away. And this is survival of the patients that have a CR, CRI without going to transplant. Usually that CR lasts 1 month, 2 months. I mean, I have about 5 or 6 patients right now that are going through that relapsed life with the relapsed disease without getting to transplant in time to catch that window of opportunity. So we don't really induce patients otherwise. So if there is a donor, the patient can sustain induction, then it's reasonable to do the induction followed by the transplant. And that has been also noticed by others. This is the one summary of experience through the registry. CR prior to transplant, about 75% survival longer term, not long term, but longer term. That has to be seen whether it's going to worsen over time, but it is similar to our own experience in MD Anderson. If you do transplant otherwise, the outcome is very bad. So it is important to reduce the patients back to chronic phase with induction or complete CR before you go to transplant. And the proportion of patients that actually can do that is very small, right? We are not talking about a large group of patients that actually can do that induction and has a donor. That's the win-win situation, plus the CR to the response. So a very small proportion of the patients that actually can achieve that. So a large number of others just simply die. So we and others have tried to see what would work in this situation. The information in the table is just for you to look later. These are 3 patients that out of 18 had improvement with ruxolitinib. That's not good enough to say that ruxolitinib has activity in transformed situations, and we do not use ruxolitinib in transformed patients as a goal to treat the disease itself. We can use it for control of symptoms and signs like we use in myelofibrosis otherwise, if the patients have a big spleen and symptoms, but not that expectation is that that will do much for the acute myeloid leukemia itself. And we know, I perhaps did not mention before, that ruxolitinib would not preclude progression to acute myeloid leukemia, right? We know that in MPN that does not happen. It does not preclude progression. So the story of hypomethylation agents started also about 7 or 8 years ago with the first short paper in about 11 patients from Dr. Mascarenhas at the Mount Sinai Hospital in New York, saying that patients that are treated with decitabine, in this case, hypomethylation agents, have actually some response. They actually can live a little bit longer, and they can make it to the transplant. So some possible sign of a benefit of hypomethylation agents in this detrimental situation. Otherwise, that was expanded by experience from a multi-center study in Europe of use of azacitidine in patients with AML or MDS, and this was subgroup analysis of patients with post-MPN AML. Here there were 26 patients that had the MPN before with AML, and the CR/CRi plus PR was seen in about 38% of the patients. So about a third of the patients actually had response to azacitidine, and that was the step further in our ability to perhaps do something with hypomethylation agents to patients that are transforming to acute myeloid leukemia. There are therefore a number of studies, and I heard that from Claire that there is a study like this in the UK. You just mentioned that in the United States there are 2 studies underway where a combination of ruxolitinib and decitabine, both are ruxolitinib and decitabine, are being explored for patients either in accelerated, that means 10 to 19% blast in the peripheral or bone marrow samples, or full-fledged acute myeloid leukemia situations, 20% or more. These studies are underway. Preliminary results were shown at ASH, but I'm not going to show them in detail because it is really work in progress. I can't really say that there is something extraordinary happening with these combinations so far. There are some activities, but too early to say. Again, ruxolitinib in this situation is given to counteract usually symptoms and signs of a big spleen and poor quality of life, not with the goal to decrease the blasts or change the bone marrow. The ruxolitinib is symptomatic therapy. Decitabine here is active agent for acute myeloid leukemia part. Now the question is, what actually can you compare the therapies with hypomethylation agents to historical experience with intensive chemotherapy? Perhaps this is a little bit harder to see. This is our own analysis of 261 patients with AML after MPN that were seen over the last 25 years at MD Anderson. And these are the types of therapies here. High-dose RSE therapy was given to a third of the patients, low-dose RSE therapy to about 25%, hypomethylation agents to about a third of the patients, and others, these are studies, only about 10%. So we had quite a group of patients of 260 AML after MPN patients that were roughly given about a third of them, either high-dose, again, based RSE regimen, low dose, or hypomethylation agents. And these are the responses here. There are about a third of them would go to the CR, and it is about the same result whether you give it high-dose RSE, low-dose RSE regimen, or hypomethylation agents. No difference. But first of all, you need to realize that the chance of response is about a third, right? The third of the patients regardless of the regimen, will go to the CR. When you see a new patient with the de novo AML, what do you usually tell the patients about the chance of response? Hardly ever that you say less than 50%. Usually you say 60, 70% chance of getting to CR, high risk of relapse within 1 year, overall survival perhaps less than 50%. But here, in this situation, chance of having a response is only a third, 30%. And what the positive part here is that you don't need really to go to the induction chemotherapy. It is hypomethylation agents. This just supports the notion that hypomethylation agents have a role equal to the induction chemotherapy, and it can be given in outpatient setting with less toxicity to patients in these particular situations. This type of information was needed for us to put in the NCCN guidelines. I'm not sure whether you are aware of this. It's online from October and published recently. The guidelines from National Comprehensive Cancer Network, 27 centers combined together, trying to advise people in the community what to do when there is a progression. So these are some background information of assessment of the situation of the patients, but here we go. Myelofibrosis accelerated phase, 10 to 90% of peripheral blast or bone marrow, or a blastic phase, equal approach. Why equal approach, one would say? Because the outcome of these patients appears to be equal, actually. 10% or higher is similar to 20% and higher, and there is no much difference in retrospective analysis. Papers exist on that topic as well. So we assess these patients in the same way, Is it transplant candidate? If there is a donor and transplant candidate, then induce remission either with hypomethylation agents or intensive chemotherapy, because they are equal in their ability to induce CR and then followed by allogeneic transplant. If there is no transplant or no transplant candidate, trials are always a possibility, but then we suggest hypomethylation agents or low-intensity induction. There is no high-intensity reduction mentioned here. There is no high-dose RSC mentioned as a possibility because there is no really difference in that achieving on CR, and it's more toxic. We prefer to do hypomethylation agents in outpatient setting. Quality of life is an issue. It's short, but why not make it outpatient and good quality of life? So this is now actually published. I have a blue arrow here. It says ruxolitinib may be continued for improvement of splenomegaly or other symptoms. Many patients can be progressing from myelofibrosis while on ruxolitinib. We do not stop it. We add hypomethylation agents when we see more than 10% blasts, or if they present de novo with 10% or more blasts and have a big spleen and symptoms, we use ruxolitinib in that situation on top of hypomethylation agents. And this is becoming standard of care, as you can see, at least in the United States. There are others that are looking for novelties in this setting. Just 2 slides to say that there is a movement to find something new. This is BET bromodomain inhibitors. Phase 1 studies are underway that include patients with post-MPN AML specifically because of activities. I don't want to go in detail, but just to give you a flavor that yes, this as a niche for drug development is being recognized. Now that we have good knowledge about the genetics and the therapies and potential of these therapies or lack of potential, and one can actually envision development of a drug specifically for AML after MPN. The numbers overall within MPN is small, but is detrimental, and the life is so short that there is a high need for novel therapies. So in conclusion, we went through the risk factors, the conventional risk factors. We went through the genetics and the roles of the mutational spectrum in identifying what possibilities exist there to perhaps intervene. I tried to emphasize the lack of real benefit of induction chemotherapy unless there is a donor ready for patients that are in accelerated blastic phase, and that hypomethylation agents are becoming standard of care. We certainly need to develop new medications for this particular group of patients, and this is where the common effort from all of us is to combine efforts and develop the studies together, because after all, this is a rare condition, but it's so deadly and we need to address it. Thank you very much for your attention.